Dear ladies and gentlemen, I would like to present you our study on safety of physical treatment modalities and compliance to treatment in female patients with lower urinary tract symptoms, a perspective from real-life data. First choice of treatment for lower urinary tract symptoms are mainly conservative management, like physical treatment and rehabilitation modalities, including biofeedback, electrical stimulation, behavioral treatments like bladder training. Adherence to non-pharmacological conservative treatments is crucial because efficacy depends mainly on patients' compliance. Clinical trials focus mainly on efficacy results, as we know. These modalities are mainly safe, but do we know how safe they are? So our aim was to explore safety and compliance for physical and rehabilitation modalities used in LUTS. This was a retrospective study. We extracted data from our pelvic floor disorders rehabilitation unit database from 2018 until 2021. Female patients with LUTS registered to any treatment modality was taken. Disease. Pelvic floor rehabilitation regimens given to patients was behavioral management, biofeedback, and electrical stimulations. Bladder training was for patients with overactive bladder syndrome. There was a weekly arrangement of voiding schedules for 8 weeks, including lifestyle modifications and coping strategies for urgency. Biofeedback consisted for 45-minute sessions once a week in a total of 6 sessions. Electrical stimulation was delivered transcutaneously as tibial nerve stimulation in patients with overactive bladder. Each session was 30 minutes twice a week and a total of 12 sessions for 6 weeks. In some selected patients where they would like to go on, maintenance program was once a week for 6 sessions. Intravaginal stimulation was used for stress in urinary incontinence patients for weak urinary muscles. Each session again was 30 minutes and 4 days a week with a total of 20 sessions were delivered. All treatments mentioned above were subject to an extension period in case of a patient's need. Treatments were delivered alone or in combination. We recorded every session, its frequency, total number of sessions, type and route of modality, adherence to treatments, any adverse event during the treatment and in the follow-up period. Compliance to treatments was calculated in percentage. Number of completed sessions divided by the total number of planned treatment sessions. And we also recorded number of patients completed all the planned sessions. 102 female patients with lower urinary tract symptoms had mean patient age 48.9 with mean body mass index 31.1. The distribution of the diagnosis was 41% had overactive bladder, 12% had stress urinary incontinence, and 41% had mixed type of urinary incontinence, organ prolapse. In the table, you can see our results for compliance and adverse events according to treatment types. 25 patients had behavioral management, 40 had biofeedback, 32 in the intravaginal stimulation, and 68 in the TTNS group. Compliance was 91 in bladder training group, in the intravaginal electric stimulation treatment group. One patient had vaginal infection. and one patient had vaginal irritation, which was terminated due to her old age. Bladder training, biofeedback, and electrical stimulation, either intravaginally or transcutaneously on tibial nerve, seem quite safe for patients with LUTS in the conservative management of the disease. Intravaginal stimulation was the only treatment modality with adverse events. However, even for it was adverse events were mild and low. Randomized controlled trials give us unbiased information about the safety of these modalities, but clinical experience is also important to observe safety results for a clinician. Compliance to all treatments was high. Unexpectedly, adherence to biofeedback was lowest, despite its weekly feasible schedule. This might be due to socio-cultural tendency of our patient population for passive treatments instead of active treatments. We didn't have a control group to compare treatment compliance, but we also consider that adherence and compliance might differ in clinical trials compared to real life due to the artificial nature of the trials. As a conclusion, physical modalities and rehabilitation methods used for pelvic floor dysfunctions are quite safe and tolerable. Compliance to these regimens is relatively high, and adherence depends on patients' treatment preferences. We need larger prospective long-term controlled trials to understand the dynamics of patient compliance for pelvic floor rehabilitation methods. Thank you for listening.